Welcome to Unscripted, the AMCP podcast, a look inside managed care pharmacy.
Imagine waking up every morning, day after day, month after month, feeling unrested and fatigued. It's so profound that literally every aspect of your life is affected. Relationships, jobs, education, searching for an answer that often takes more than a decade to figure out what's going on. That's the lived experience for many patients with idiopathic hypersomnia, a neurological sleep disorder that's profoundly underrecognized and carries a substantial impact on quality of life and a comorbidity burden. I'm Denise Wolfe, and this is AMCP Unscripted. Today, I'm here with Zach Contreras, Director of Pharmacy Benefits at a regional health plan, to talk to you about what's changing in IH, how we recognize it, how it's treated, and where the payer community can move things forward. Zach, welcome.
Thanks, Denise, for having me, and look forward to our second chapter on this subject.
That's awesome. Well, let's start with the discussion on the disease itself. Zach, for listeners who may not have IH on their radar, give us the orientation. What is idiopathic hypersomnia? Who's affected? And what makes it clinically distinct from how most of us think about insomnia?
Idiopathic hypersomnia, or IH, as we're going to be referred to it, it's a chronic neurological sleep disorder. And this is characterized by people having what they call sleep inertia or sleep drunkenness. They sleep long hours, 9, 11 plus hours a day, but all that sleep is unrefreshing. So they don't wake up and they feel good. They're still tired and drowsy. And the cause for it's unknown. Very often this gets confused with narcolepsy, which it's not. Yeah. So it's a different type of, metabolic type of disease than narcolepsy is.
Sure. Okay.
It impacts young adults, 10 to 30 years old, mainly women. And the prevalence is like 10 in 100,000 is the prevalence for IH.
Thank you, Zach. So when you sit with this patient experience, as you've just described it, the excessive daytime sleepiness, the sleep inertia, the way IH shows up at work, in relationships, in everyday function, what hits you the hardest?
You know, we saw a video that you presented a while back on a patient that had IH. The thing that hit me the hardest, it was the young lady made the statement of, I gave up, I'm not going to have children. It breaks your heart when you hear something like that.
Right.
Because she'd been struggling with this for years and did not have, the resources, or was not diagnosed proper. Yes, it impacted her quality of life. It impacted her relationships, obviously, and her job. She talked about her job, getting to work, and the issues she had with that. Touches me the most is obviously it's the quality of life that people with IH have to deal with and live with on an everyday basis.
Yeah, very profound, very significant, very real. That video was a physician, a woman who actually went to be a physician, and it hit her, after, as you said, after she was a doctor, and ended up having to leave practice. I mean, it was very, very profound. That diagnostic delay, on an average, it's more than a decade, which seems incomprehensible when you give those prevalence numbers. It probably makes sense. Like, it's really hard to understand what this is. Diagnosis is a challenge. It's a very striking number. What's behind that? What's driving that delay?
Well, there's several factors, in my opinion, that are driving that. First of all, people don't know what IH is. I describe IH to, my colleagues and saying, hey, I'm, doing this podcast on IH, and they kind of give me the strange look like, what is that, right? And I have to explain it to them. Yeah. So let's just start there, right? That's the first piece of it. But then as we get into, what delay in diagnosis is, that a lot of these patients with IH are going to the primary care providers. And the primary care providers also don't have the awareness of diagnosing IH, or that the patient might have IH at all. So they're often diagnosed with sleep disorder or depression, anxiety, right? Maybe chronic fatigue. And so they're being misdiagnosed the entire time. And then they're mistreated as well with the wrong medications. And what happens is then as a plan on my side, if I want to find my members with IH, you can't find them because they're invisible in my data because that doesn't pop up. So, the lack of the PCP awareness is another very key piece to the diagnostic delay. Then once we want to go ahead and do referrals, by this time, there's sometimes delays in referrals, prior authorization referrals, prior authorizations for the drugs, prior authorizations for sleep tests, right? There's all these steps that just continue to delay the diagnosis. And, and when we talk about, what can we do to streamline, these are areas that plans feel should look to be able to streamline so the members don't have to wait and go through this prior authorization process and every step of the way to be able just to get a sleep test and get a diagnosis.
Yeah. Yeah, absolutely. I mean, from hearing you talk about it, it sounds like it's definitely not an unsolvable mystery, right? Like we know the pieces, we know the building blocks, but it's almost like it's a series of operational and educational gaps that exist and need to be addressed within our health system. And we need to have the health system take action on this on behalf of these patients. There's no question. We're going to come back to this. I want to transition for a moment to a pharmacotherapy discussion. So let's say we have a patient who's now been diagnosed with IH, and I'd love to hear you tell us a little bit about what's in that treatment toolkit, as well as what are the goals of pharmacotherapy for these patients.
Yeah, well, the treatment toolkit, what we see most are drugs for wakefulness, such as modafinil, right, or solriamfetol, are usually the drugs that are prescribed at the beginning, as well as stimulants or amphetamines. Those seem to be the ones prescribed initially for IH. As a plan, what's really interesting is that specifically on the stimulant side, when we see our prescription and our top 10 prescriptions, you're going to see stimulants in there. The IH member gets lost in that. If they're on the stimulants, they get lost in because those are mostly prescribed for ADHD.
Okay.
So again, they're getting lost in there. That's another area that, we need to look at and we might want to come back to later on. But that's another, those are a couple items that are, drugs that are in the toolkit. But obviously the most recent one is the sodium oxybates. Sodium oxybates are actually indicated for IH. The other ones are being used off label. Sodium oxybate it works in a different manner. It works on the sleep regulation of patients with IH. So these are the newer treatments. What plans are doing now is you have sodium oxybate and you have low sodium oxybate now out on the market. What's happening with the plan side is that these drugs, while they require prior authorization, now you're going to start to see step therapy from a sodium oxybate to a low sodium. And that's because there are generics coming out for sodium oxybate out in the market. So I think what we have to do as a plan is for patients that require maybe a low sodium diet, such as they have hypertension or cardiovascular disease, those members, we want to be able to provide some type of path so you can bypass the step therapy and allow them to be able to get the low sodium oxybate. So that would be built into, if there's a prior authorization, built into the prior authorization criteria, such as, they have to do step therapy unless, of course, the member has, hypertension or on a low sodium diet or requires some type of low sodium diet, then they can get low sodium oxybate.
Okay, that's good. So it's good to understand that treatment is evolving for IH.
Right.
It sounds like the low sodium oxybates represent a meaningful innovation. The pharmacological profile matters, given what we now understand about IH and cardiovascular risk. And that's been an evolving learning as well. That lack of sleep and the what comes first, the chicken or the egg. We're
Right.
getting some very concrete data on the connection there. In fact, one of the most striking findings that I was reading about in the idiopathic hypersomnia evidence base is that these patients have roughly double the odds of cardiovascular disease compared to the non-IH control groups. That was very striking. I know we talked about it in Nashville as well, but how has that finding reshaped, over time, when you think about over time how we've learned so much more, how has it reshaped how you think about IH and what considerations that our payers and listeners should have on this category?
Yeah, the cardiovascular risk is staggering when you look at it. Person with IH is over 2 times more likely to have some type of cardiovascular disease than a person without IH, right? From a payer standpoint, when you look at, well, why do they have this cardiovascular disease? I think the delay in diagnosis is a direct contributor to that. Being able to diagnose them earlier and identify the members within your data and look for patients potentially with IH so you can intervene early on. And if you can intervene early on, you can recommend them to some population health within your plan, and then they can work with the member to get them, on the right medications, right treatments, get them any behavioral health, services that they need, whatever it is. And then that in the end will obviously, help with our total cost of care and treatment. So yes, that's really important.
It sounds like the IH treatment decision shouldn't be made in isolation, Zach, based on what you're saying and what you've covered, that the comorbidity profile of each patient matters, and that coverage frameworks should make room for individualized clinical treatment decisions. I mean, you've made a great case for that. Beyond therapy selection, then, what are the meaningful levers that payers can actually pull to improve outcomes in IH? Kind of, we're back to kind of the holistic look at things, whether that's upstream education for primary care, referral pathways, making efficiencies there, prior auth design, provider attestation, things along those lines. How can we make a difference with the outcomes here?
First of all, I think PCP awareness is probably number one, since members go to their primary care provider first, providing education to them around early recognition, right? I am fortunate enough to work with 2 great medical groups within our system. When we put together policies and we have what we call JOCs, Joint Operating Committee meetings, we can speak about early identification of members with IH. And then that's filtered down to the system from the medical groups and the directors to the rest of their team, right? And I work with the pharmacy team as well, that they do the same. So, that PCP awareness, is a great touch point. And I think the first touch point as well. Other areas we think about is, again, the streamlining access, which we spoke about, to sleep specialists. Access to care is a big issue. And what we see when a member is not able to have access to care is we'll see these pop up in maybe member complaints. And with the member complaints, that kind of alerts you that, we have an issue of access here. So how can you streamline that access? Instead of requiring a member see a sleep specialist, maybe it's a consult, right? It's a little bit easier pathway. Same thing with the testing. When you look at your prior authorization processes and requirements, if you're going to put prior authorizations on these drugs, if there's an issue with testing and it's difficult to provide, or there's going to be some delay, build within your PA criteria, allow a trial for 3 months. These members have been going through this probably, like we talked about, for 10 years, right? Well, they're at that stage. So, the 3-month trial will tell you a lot. If it works, then you've got the right diagnosis, you've got the right treatment, and you could start from there. And then we have provider attestation reviews. That's another one. Again, talked about the consultation or allowing them to provide attestation for that. So that's a key one. And I think one, if when I think about going back into our advisory committee, one area that we talked about was updated clinical guidelines. That's really something that plans rely on quite a bit when they're writing prior authorization criteria. So ensure that disease state guidelines are updated.
Absolutely. And as soon as they come out, there's always that period of time when there's a gap there, but holistically thinking about the data that's available in that transition and what's best for the patient is certainly okay. I love that. And I love how you described, like within your health system, being able to go back up into the system to primary care and pharmacy and be able to connect the dots so that we can meaningfully touch these patients so much earlier. Like you said, you can't pick them up on case population management because just with the script they have, right? Because there's more to the story. So I think you pointed out some really valuable things that are going to be really important for our listeners to take to heart if we're going to be able to change the course here and bring some earlier detection and accurate diagnosis and effective treatment to our patients. If you were our listeners and you could help them realistically, identify acting on one thing, just one thing to get this started in their health plan, because it can feel like a lot. But what is that most meaningful thing? What would you point them to and why to be able to take IH to the new world, a new situation, a new outcome scenario for these patients? Where do they start and why?
I'd go back. It's the lowest hanging fruit is your prior authorization criteria. Allow provider attestations and or build in the 3-month trial. That's the quickest, easiest, low hanging fruit. You could touch it right away. Yeah. And have an impact.
That's a great one. So let's ask our listeners to take that action. Zach, the last word to you today. I would love to have you speak to our listeners in terms of your final thoughts on idiopathic hypersomnia and the importance of the work they're doing in managing their health plans and their pharmacotherapy programs.
Yeah, my final thought would be wake up. Okay. And I say that because our job each and every day is to provide the best outcomes at an affordable price, and being able to touch our members and ensure that they are receiving this quality of care. I'd encourage them to go into their data, dig through the data, find patients with IH, identify them early. The earlier you're going to identify them, the less likely they're going to have long-term effects such as cardiovascular disease plus other comorbidities that go along with IH, which all in the end decreases your total cost of care. And that's what we're trying to do.
Right. Absolutely. Well, that's some amazing advice to our AMCP Unscripted members today. We're asking you to wake up. The full AMCP Market Insights program on idiopathic hypersomnia is actually published in JMCP, and the link to that is in the episode notes. So feel free to look at that. Zach, thank you so much.
Thanks, Denise, for having me.
And to our listeners, thank you for spending a few minutes with us today on AMCP Unscripted. Have a great day.